Welcome all to the 12th episode of Vertical Integration. So, today we have got a very interesting topic and we have got an expert panel. Today we will be discussing regarding acute diarrheal disease in children. So, we had 4 expert panelists from the Department of Physiology, Dr. Vandana Madam, she is a professor in the department, and from Department of Community Medicine, we have Dr. Chitra Tommy, who is again an additional associate professor. And from the Department of Microbiology, we have Dr. Purnima, again additional associate professor. And from the Department of Pediatrics, we have Dr. Shailash, who is the senior resident and consultant in the Department of Pediatrics. So, without much delay, we'll start off with the questions, ma'am. As usual, we'll start off with physiology. Ma'am, can you just briefly explain the physiological mechanism that lead to dehydration in children in acute diarrhea?
See, when we, I would say that there are no, it's not physiological mechanisms, it's actually pathological mechanisms which lead to dehydration. So I'll just explain the physiological mechanisms which normally prevent.
Sure, ma'am.
I'll talk about general regarding this water reabsorption.
Sure.
So we'll just assume that suppose we consume 2 liters of water, then almost 7 liters of water is actually secreted into the gut through the various gastric juice secretions, various secretions in the gut. So what happens is normally only 100 or 200 ml is lost through feces, and almost 8,800 ml is reabsorbed. So this reabsorption normally it occurs along with sodium and glucose and other molecules. So it occurs along with sodium into the cell, and from the cell into the ECF. It goes by sodium potassium transport. So along with that, water also enters ECF. So this is what happens normally. When this is affected, water reabsorption is affected, or when there is excess secretion, as in case of some bacterial infections, when this water secretion is increased due to the modulated through G proteins, as in case of cholera. So when there are chloride channels which actually drags water into the tract. So in such conditions, there may be secretory diarrhea, and in case of some conditions where there is actually the intestine epithelial cells are lost. So there, normally what happens is there is a secretion of disaccharidases and dipeptidases, which actually help in the digestion of these molecules. So when these cells are lost, normal digestion, for example, lactose, if it is not digested, so it increases the osmotic activity here and it drags water. So there is more osmotic diarrhea in that condition. So these are the normal conditions, normally how it results in excess secretion of water, excess loss of water. And then in children, if you look at this, it's more complicated because of the ECF-ICF ratio is more in case of children, and the regulatory mechanisms are also poorly developed. So this is all.
Okay, ma'am. Thank you, ma'am. Thank you for a brief introduction regarding that. Over to Purnima, ma'am. Can you just briefly identify the common bacterial, viral and parasitic pathogen causing acute diarrhea in children?
Okay, so to classify the etiological agents, we can classify them in different ways, like based on the age group of the child. Any child who is less than 2 years or more than 2 years, and based on the diarrhea, whether it is a watery diarrhea or an invasive diarrhea, basically a dysentery kind of thing. So if it is a child who is less than 2 years of age, the most common pathogens that we encounter are the viral ones, like rotavirus, norovirus, etc. And sometimes ETEC, EAS, etc. can be identified. Then if the child is more than 2 years of age, it is more of the bacterial pathogens. So Vibrio species, the classical rice water diarrhea. Vibrio cholerae, then you have the Vibrio parahemolyticus, etc. Then more importantly, the Shigella species, Shigella flexneri, Shigella dysenteriae, sometimes Sony and Boydii. Then also along with that, you have Campylobacter species like Campylobacter jejuni, Campylobacter coli, then Aeromonas, Plesiomonas. These are the other common pathogens. So coming to classifying based on watery diarrhea, again the viral diarrhea like rota, noro, etc. and Vibrio cholerae can cause watery diarrhea, and almost all your other bacterial pathogens, EHEC, EAEC, then Shigella, Campylobacter, all these will cause an invasive kind of diarrhea, which is diarrhea with blood and mucus in stool. This is how the etiological agents are classified.
Okay, ma'am. Any parasitic pathogens that we need to consider?
Parasites, not very commonly, but sometimes you might see Entamoeba histolytica as a common pathogen, and sometimes it might not be an infectious agent as such, but if you happen to see, it could be a Giardia lamblia or Giardia intestinalis cyst that can also be seen. So that is also a pathogen.
Okay, ma'am. Thank you. Over to Chitra, ma'am. Ma'am, can you just enumerate what are the key factors that is contributing to the high burden of acute diarrheal disease in developing countries like India?
So, diarrhea as such, it contributes almost 8% of the death among under 5 children, and in India it is up to 10%. And in developing countries, like a child under 5 child, like median episodes would be average 3 episodes per year, and in a developing country almost 3/4 of the children will have at least 1 episode of rotaviral diarrhea by the age of 1 year, but in a developed country it will be delayed. And also in a developing country almost universally it is infectious in origin. And some of the factors which are contributing to this infectious origin are like the breastfeeding, suboptimal breastfeeding practices, then the drinking water supply, whether it is inadequate drinking water supply, then the sanitation, hygiene, then the malnutrition, then other factors like even maternal education status and all. And in coming to the each component in the breastfeeding practices, suboptimal breastfeeding practices in the developing countries like India, so there are habits of like certain customs like giving pre-lactal feeds there. Then also there are some pockets of areas where there are people who discard the colostrum, which is highly nutritious part of the breast milk. And also ideally the recommendation is to continue exclusive breastfeeding up to 6 months. So but still there are customs, it is part of the culture to start the ceremony to give the food early before the 6 months itself. So weaning practice will be starting earlier. So these are some of the aspects with regard to the breastfeeding. And also with regard to the drinking water supply also, in the developing country, from the collection point to the storage, transport, and also the consumption point, there can be contaminated. So in the collection point, if you are collecting water from a pond or a well water, if it is not properly covered or fenced, properly treated, they can be contaminated with human or animal feces or birds droppings, or it can be there. And even even if it is treated water, some places in urban areas in developing countries, there can be treated water distributed, but that distribution it may be in the alternate days, not on a regular basis. So there can be cracks in the pipes, and there will be a negative pressure always. So contaminants, there's chance that contaminants can enter the water supply. Then even if everything is right in the consumption point itself, that is where the water, whether it is storage if it is inadequate, or the handling if it is inadequate, it causes problem. Then hygiene and sanitation also, many places sanitation is improved sanitation facilities are inadequate. Then hygiene, safe hand washing practices are inadequate, like so if at least after going to toilet and before feeding the child, we should hand wash with usually the washing is only with water, should wash water and soap. Then the malnutrition, definitely it causes diarrhea. Then again other nutrient deficiencies like vitamin A or zinc, then inadequate coverage of the vaccine. Also maternal education to some extent can contribute to low maternal education can also contribute to diarrhea among children in the developing countries.
Okay, ma'am. Thank you. Dr. Sheila, can you just differentiate between acute and chronic diarrhea in children based on clinical presentation? So what will the basic thing when we say diarrhea, the parents will get panic, so they will come have sometimes chronic diarrhea and acute. Second, can you just elaborate on it?
Yeah, so basically in diarrhea in children it is classified as change in consistency or the frequency of the stool.
Okay.
So the consistency, it can be watery or liquidy like stools.
Okay.
And usually the frequency, if it is more than 3 times per day,
Okay.
we took it as a diarrhea.
Okay.
So usually the cause of diarrhea, as the madam told, the cause usually in children will be of viral. So usually these viral diarrhea subsides within 7 days, almost 7 days. So those diarrhea we classify it as acute diarrhea.
Okay.
But in around 5 to 15% of cases, these diarrhea may persist for more than 2 weeks,
Okay.
more than 14 days. In such cases, we call it as persistent diarrhea.
Okay.
But usually, the causative agent or etiological agent of this persistent diarrhea used to be this infectious cause, actually. So, that is acute diarrhea and persistent diarrhea. So, persistent diarrhea actually it starts as an acute diarrhea, but it may last more than 2 weeks.
Okay.
So that is persistent diarrhea. But in case of chronic diarrhea, usually those children, their symptoms starts as an insidious onset, as in a subacute diarrhea.
Okay.
It won't be like acute severe diarrhea, but they starts as in a subacute onset, insidious onset, and later it progresses more than 2 weeks.
2 weeks. Okay.
So that is usually the how we differentiate between the persistent diarrhea and chronic diarrhea, even though both of them last for more than 2 weeks.
2 weeks. Okay.
So that is the basic difference.
Okay, fine.
So in chronic diarrhea, we actually has to rule out other malabsorptive disorders based on the age of presentation and all. It may not be always infectious etiology in case of chronic diarrhea.
Chronic.
So that is the basic difference.
Okay. Thank you, ma'am. Coming back to Vandana, ma'am. Ma'am, we were talking regarding this diarrhea. So, how does this acute diarrhea or whatever be the chronic diarrhea affect the intestinal nutrition absorption in children?
See, here when due to the infection, if the epithelial cell, again what I mentioned previously,
Yes, ma'am.
same thing, if the epithelial cells are lost,
Okay.
then the normally what are the enzymes which are secreted from
Okay.
the epithelial cells, they are not being secreted.
Okay.
Then so mainly the disaccharidases which cause the digestion of these disaccharides as well as the peptidases. So these enzymes are absent here.
Okay.
So their digestion as well as absorption is affected. So when their concentration increases, it further worsens
The diarrhea. So it is like both the absorption of all the required minerals, electrolytes, everything is going to get affected because of this. Okay, ma'am. Okay, thank you. Coming to Dr. Purnima again, ma'am, can you difference how different pathogens cause a diarrhea through their mechanism of action? You said regarding E. coli, rotavirus, etc. So, what is the classical difference that we can?
Okay. To start off with, I would say that the route of transmission is the same in all these pathogens.
Okay.
It is a fecal-oral route of transmission,
Okay.
and it is through contaminated food or water that the child will get the diarrhea.
Okay.
So, and as Madam was saying, diarrhea, you can classify it as osmotic and secretory. And it is a secretory diarrhea that is seen in the infectious agents, in the case of infectious agents. So here, again, the physiology was mentioned by Madam. So here, what is happening is, there is an over-secretion of fluid and electrolytes, and there is a pooling in the lumen, and that causes a watery diarrhea. That is what is happening. And this basically happens through toxins. Okay, there are toxins. As far as bacterial pathogens are concerned, there are toxins that are released. It could be an exotoxin or an enterotoxin. And similarly, viral pathogens like rotavirus also have certain toxins. But in viruses, there is a disruption of the epithelium that is happening, and that is also contributing to the pathogenesis. So, cholera toxin, the same thing, there is an increase in cyclic GMP, and there is a pooling of water and secretion is happening there. Then there is SHET, which is Shigella enterotoxin. So that is another way in which the disease is, the transmission, pathogenesis happens that way. Then there is the EHEC, which is enterohemorrhagic E. coli, also called as Shiga toxin producing E. coli, which has a mechanism the same way as water secretion and pooling in the lumen. Certain of these organisms also have a type 3 secretion system in their pathogenesis. So this type 3 secretion system is also hampering the epithelium. The colonic epithelium is hampered, and that's another way in which the pathogenesis happens. So broadly, it is toxin mediated in bacterial through cholera toxin or SHET or any of those toxins, and in rotavirus, it is through the NSP4, non-structural protein 4, which is again acting in the rotavirus. So that's how the pathogenesis happens.
Okay, thank you. Coming back to Chitra, ma'am, okay, you said regarding the lacunae in the breastfeeding and all. Can you explain the strategies how we can promote breastfeeding and safe weaning practices to prevent acute diarrhea in children?
Okay. Basically, main worldwide main two policies are adopted is one is baby friendly hospital initiative and also infant young child and feeding practices. So based on that, the infant young child feeding practices were put forward by WHO in 2002, and we have also guidelines based on that on infant young child feeding practices. So main strategies in that is one is the early initiation of breastfeeding as soon as possible after delivery, or at least half an hour after delivery. And then second thing is the exclusive breastfeeding, at least for 6 months. And exclusive breastfeeding means not even any water or any juices or any other fluids. Actually, even in a high temperature climate, the breast milk is enough to tackle the dehydration of the child. And then after exclusive breastfeeding, by 6 months, the child is getting the nutrients and the fluid from the breast milk itself. And after 6 months, by 6 months, it is recommended to start weaning with the complementary food. We are complementing the breast milk. So complementary food should be started by 6 months. And that also with the locally available cereals, properly cooked cereals or vegetables and mashed vegetables and fruits and with the liquid consistency, you can slowly increase the consistency. And with regard to, and meantime, the breast milk, other recommendation in the IVCF is to continue breast milk till the age of 2 years along with that. And also one more aspect that I mentioned is that strategy is like, along with the weaning practices, it should be safe. So as I mentioned earlier, you should have a safe handling, hand washing should be there. Then even the vessels used should be properly cleaned and dried. And also after cooking also, the food should be kept and covered. And in resource poor settings, the food should be used, if refrigerator is not there, should be used within 1 or 2 hours. And also these are the aspects. And one more thing in regarding promotion of breastfeeding and is for working mothers, there is the one strategy is like there is maternity leaves are there, so they can continue the exclusive breastfeeding. And there is in some places there are places separate rooms for expressing the breast milk and storing, and especially in there is something called Hirkani rooms put forward by government of Maharashtra, where they have separate rooms where they can store the breast milk. So that is there. Along with that, in the hospital sides, we have the baby friendly hospital initiative is also there.
Okay, thank you. Coming back to Dr. Shaila, can you explain the clinical features? Very important to suggest dehydration in child with acute diarrhea.
So in case of diarrhea, whenever a child comes to the OPD, it's very key. It's the most important thing to assess the dehydration in a child.
Yes.
And the management of diarrhea is always based on the dehydration status of the child. So dehydration, we actually classify it as no dehydration, some dehydration, and severe dehydration. Basically what we do is we ask, we look, and we feel. That's what we come to know, like how severe the dehydration is. So in case of no dehydration, we ask, to the mother, whoever the bystanders, we ask how is the thirst of the child, how is the activity of the child. So a playful child, alert, active child, drinking as usual at home. So next level is look at the child. So how is the child? The sensorium is good, eyes are normal, tears are normal, the oral cavity, the tongue, the lips, everything looks normal, not looking dry, or its moist content is there. And the next thing is we feel for the skin turgor. Okay, so the skin turgor, we basically halfway between the umbilicus and the side of the abdomen, we see for the turgor. And if it is delayed, means it will the fold will not last, will disappear immediately. That means there is no dehydration. If it goes very slowly, that is more than 2 seconds, it indicates severe dehydration. Okay. So no dehydration. Then next comes the some dehydration. In some dehydration, the child will be a little bit irritable. The child will be drinking. The thirst will eagerly will be drinking water. The child's eye will be sunken. The tears will be absent. The mucosa oral cavity, the mucosa, the lips will be dry, and the skin turgor also will be delayed. Will go back slowly, but it won't be more than 2 seconds. So that is some dehydration. And in severe dehydration, where the child will be very lethargic, poor sensorium, floppy child, and when we look at also very sunken eyes, the tears will be absent. It will be very dry tongue and the oral cavity. The skin turgor will also delay by more than 2 seconds. So this is how we differentiate between no dehydration, some dehydration, and severe dehydration. And regarding the management also, it differs. For no dehydration, we actually can manage at home. So we can just replace the ongoing losses with the oral ORS with the 10 ml per kg for each loose purge. And then the second step is we always continue the normal food what we used to give for the baby. And the third step is always explain the danger signs to the mother. Explain the danger signs, like if the stool output is more than 5 ml per kg per hour, or persistent vomiting, that is more than 3 episodes of vomiting in 1 hour, or any blood in stools, any fever, any poor activity, any inability to drink. All these are the danger signs which you should explain to the mother based on the dehydration status. If it is no dehydration, we have to do these things.
Okay. Thank you. Ma'am, coming back to Vandana ma'am. Ma'am, can you just say what are the hormonal changes? Anything that happens during the acute diarrheal disease?
Actually, what prevents this water loss is actually aldosterone.
Okay.
Aldosterone actually helps reabsorption of water in the intestine. There is aldosterone sensitive co-transporters which actually helps in reabsorption of water. Then in diarrhea, we see that there is more secretion of VIP, acute intestinal peptide, and enteroglucagon, which actually increases water secretion. And motilin and prostaglandins are found to be more in diarrhea because they increase the movements. So this is how the hormonal
changes happen. Thank you, ma'am. Coming to Purnima madam, what are the key laboratory investigation that we need to perform in an acute diarrheal microbiological aspects?
Okay, so to talk about laboratory investigations, we need to know what sample is the right one. So since it is diarrhea, the best sample would be freshly passed stools. Rectal swab is not indicated. It will be better if we get freshly passed stools. And the first thing that you can do with stool is stool routine examination, which is microscopy. So under microscopy, you will be able to see pus-cells, RBCs, and in some cases, if it is a parasite, you might be able to see the cyst or ova of the parasite, as in Entamoeba histolytica. So that's one, the microscopy. You can do a wet mount. Then the next commonly done lab test is the stool culture. So for culture, we are basically looking at the bacterial pathogens, your Shigella species, E. coli, and in some cases, non-typhoidal salmonella can also cause diarrhea. They can also be identified using culture methods. So the problem with stool is, we all know that our gut is teeming with commensal flora. So if you just culture your stool, it is a commensal flora that is going to overgrow. It will overgrow and the pathogen will not be seen or identified. So for which we need to have selective media or enrichment broth to pick out these pathogens. So what the selective media like TCBS, or which is thiosulfate citrate bile salt sucrose agar, for Vibrio cholerae, and like XLD, xylose lysine deoxycholate agar for Salmonella and Shigella. What these will do is they'll inhibit the growth of the commensals and it will let the growth of the pathogen. Similarly, you have enrichment broth which are liquid media like selenite F broth for Salmonella Shigella again, and alkaline peptone water for Vibrio. So these can be used wherein you can inoculate the stool sample and incubate for a period of 16 to 18 hours and then subculture onto a solid media. So this will also select out the pathogen. And on each culture media, there are respective kind of growth, like McConkey agar can also be used, wherein lactose fermenting and non-lactose fermenting colonies can be identified and the organisms can be differentiated on all these media. Similarly on XLD and TCBS also. Once these colonies are grown, we'll have to perform appropriate biochemical tests and identify what the organism is. You can do a gram smear wherein gram-negative bacilli will be seen and you can identify what the organism is. Finally, for confirmation, we need to do something called as agglutination or serotyping. So specific anti-sera will be used, and you can identify what serotype it is. This is done in Salmonella, Shigella, Vibrio cholerae, etc. So this is about culture. As far as viruses are concerned, like rotavirus and norovirus, etc., we have antigen detection kits which will pick up the antigen, and stool sample can be used for these tests. Then for toxin demonstration, we have cell culture assays, toxin neutralization assays, which can be used for toxin identification, but that's not routinely performed. And last but not the least, we have molecular assays like your multiplex PCR panels, GI panels, which will have all the pathogens, all bacterial, all meaning almost everything, all the bacterial pathogens, all viral, and some protozoal pathogens. But again, it's a very expensive assay, and it should not be routinely performed in a simple case of diarrhea. There are FDA approved assays from BD and bioMérieux. So GI panels can also be made use of. These are the lab diagnostic methods.
And routine blood culture.
Apart from that.
That viral blood culture,
Yes.
antigen,
Yes.
salmonella, depending upon that.
Yes.
We can
As I said, it is basically non-typhoidal salmonella that is very commonly seen in children. So Vidal is mainly for typhi and
maybe
paratyphi
typhi,
and other
paratyphi.
things. So yeah.
Okay, thank you. Coming to Chitra ma'am again, can you just tell me the role of improved water sanitation and hand hygiene, specifically programs, in reducing the incidence of acute diarrhea? We have already discussed, maybe you can just elaborate on it a little bit more.
Definitely, wash programs, water sanitation hygiene programs definitely helps to decrease diarrhea. So, with regard to when you are taking the prevention indicators of diarrhea, two important indicators are the percentage of population having safe drinking water. The other aspect is percentage of population having improved sanitation facility. So, some of the programs that are concentrating on this are one is the Swachh Bharat and the other one is the Jal Jeevan mission. So, in the Swachh Bharat, they are trying to achieve, they try to achieve open defecation free by 2019, and now it is a plus component also, in which they are trying to extend it to the sludge treatment and bio waste and all. And Jal Jeevan mission also is kind of trying to achieve tapped water supply, functional tap water supply in all houses in the country. So because of all this, there is percentage of population who are getting the safe drinking water is almost 96%, and the toilet improved toilet facilities is like maybe 69 plus 8% having a shared, like that it is increased. And also the diarrhea incidents over the years, like early it was 13%, and in NFHS it is 9%. Because of that, now it is like NFHS 5, the last one, National Family Health Survey, it is coming down, it is up to 7%. So because of all this, the diarrhea incidence is increased. Plus, along with that, one more aspect that need to be stressed is the consumption point, some kind of household method of treatment, like boiling, old age method of boiling water, or filtration, or chlorination, or even solar disinfection. That should also be added in the programs.
Thank you.
Okay, thank you.
Coming to Dr. Shaila again, can you discuss the basic principle of the oral rehydration therapy for managing dehydration in children? You can just, maybe you said regarding some dehydration where they can be just treated with oral rehydration. Can you elaborate on it?
Yeah. So basically, the treatment is ORS and the zinc supplementation. Okay, so the ORS, the principle actually, the madam had told all the physiological basis of that. So in any case of diarrhea, there will be pathogen-induced disruption of the membrane, the mucosal integrity. So as a result, most of the pumps, absorption pumps, will be defective. However, the glucose-dependent sodium pumps will be active. Like they will be functional and they will be intact. So the basis of this oral rehydration therapy is basically two things, that is the glucose dependent sodium absorption. Along with the sodium, the water will also come in. The second thing is always this, whatever be the oral rehydration therapy we recommend, its osmolarity should be less than that of the osmolarity of the blood. So the osmolarity of the blood is 290 millimoles per liter, and the current recommendation is low osmolarity ORS by the WHO, which is around 245 millimoles per liter, which is well below the blood osmolarity. So the keeping the intestinal osmolarity low will helps in more absorption of fluids into the tissues. So as a result, we can prevent the dehydration. So currently we are using low osmolar ORS, not the standard ORS. The standard ORS osmolarity is around 311 millimoles per liter. So currently WHO recommends to use this low osmolar due to these reasons. These are the physiological basis of this oral rehydration therapy. So as I already told, no dehydration, what we do is we give replace the ongoing losses at 10 ml per kg for each large stool pouch. Along with it, we continue the usual feeding habits of the child, and we always explain the mother the danger signs, because usually we treat this no dehydration patients at home itself. In case of some dehydration, if we assessed in the OPD and we found out that the child is only having some dehydration, we can actually send them home, but better to be observed in a medical centers or in a hospital, better to be observed. So in those cases, actually the child is having dehydration. So we have to rehydrate the child. So rehydration is basically the ORS, which is given at 75 ml per kg over 4 hours of ORS. And then along with it, we have to replace the ongoing loss, as already told in case of no dehydration, 10 ml per kg of ORS for all the ongoing losses for each loose purge. Along with continue the feeding. So if in case of if the child is, then give for 4 hours, then after 4 hours we observe the child. If again the child is having some dehydration, we have to again repeat it. Or if the child is well, now currently the child is in a state of no dehydration, we can actually come down to the treatment, the modalities of the no dehydration. Or if it is severe, we may have to upgrade our treatment to severe dehydration. Yeah, in severe dehydration, always admit the child. Always manage the child in the hospital. So we have to give 100 ml per kg of IV fluids. Basically, it will be good to use ringer lactate. Or NS also can be used, but better to use ringer lactate, 100 ml per kg. If it is less than 1 year, we are dividing the dose into 30 ml per kg and 70 ml per kg. So 30 ml per kg over 1 hour and 70 ml per kg over the next following 5 hours. So it should be given total of 6 hours. And if it is more than 1 year, this 30 ml per kg can be given in half a time. So it is in half an hour and 2.5 hours for the rest of 70 ml per kg. In case if we are unable to get the IV line for the child, the veins are collapsed and all, we can put actually an NG tube and can give 20 ml per kg per hour of ORS for 6 hours, for continuously over the 6 hours. Or we can actually put an intraosseous line also at the upper end of the tibia and can push the IV fluids if that is also not possible. Some children may not tolerate that also. With the NG feeds also, the child won't be tolerating. So in those cases, we can actually put an intraosseous line and can give this fluids. Actually, there are some, along with this WHO-based ORS, as I told, in the home-based treatment in case of no dehydration, there are multiple options available. Like at home, if you are sending them home in case of no dehydration, we can actually give rice water with added pinch of salt, or lemon water with added salt and sugar, or soup, vegetable soup with added a pinch of salt. And actually we can make, currently they are telling we can make ORS at home also, like in a glass of water, 6 teaspoons of sugar and a teaspoon of salt will be equal. Or a handful of sugar with a pinch of salt also is almost equivalent to acceptable. So they are the home-based fluids which is available. And ORS, as I told, the sodium and the glucose, it should be in a ratio of 1:1 in terms of osmolarity. So basically, the current recommended ORS contains sodium and glucose of 75 each, chloride of 65, potassium of 20, and citrate of 10.
Okay. Thank you. Ma'am, final question to you on basis of physiology. Can you just quickly tell the role of electrolytes, sodium and potassium, in maintaining fluid balance, specifically in diarrhea?
Diarrhea as such, if it is isotonic diarrhea, then actually loss of water as well as sodium is balanced. Okay. But if it is hypotonic, then what happens is more sodium comes from ECF into gut. So there is hyponatremia. If it is hypertonic solution which is present in the gut, then there is more water moving into the gut, and there is hypernatremia. Then when we look at potassium, usually it is that the potassium is always secreted into the gut. But if there is chronic diarrhea, it will lead to hypokalemia. Then in case of bicarbonate ions, if bicarbonate ions are lost through diarrhea, then it will result in metabolic acidosis, metabolic acidosis. And then, that's it.
Yeah. Okay. So basically, what we say, metabolic alkalosis in case of vomiting, and metabolic acidosis is in case of diarrhea. Thank you, ma'am. Coming to Purnima madam again, ma'am, we talk a lot regarding antimicrobial resistance, and because of antibiotic itself, we can have diarrhea. Can you just elaborate on this context?
Okay, so first up, I'll talk about AMR.
Yeah.
So something you should understand is diarrhea does not always require antibiotics. So unless and until proven that it is a bacterial cause, that it is an infectious agent, it is a bacteria, only then should you start antibiotics. Most of the time, as madam was discussing, it is low osmolality, it's a rehydration therapy, low osmolality ORS and zinc supplementation is what is necessary. And if proven that it is an invasive diarrhea with, like, say, dysentery or something like that, and the pathogen has been identified as Shigella or some specific bacteria, in that case, you can start antibiotics. So that itself will curb this problem of AMR to an extent. Then I was talking about NTS, which is non-typhoidal salmonella. So this is generally acquired from food items from milk products, dairy milk products and poultry products. So what we have been saying is, these industries, they have been using a lot of antibiotics as growth promoters, like cephalosporins, colistin, etc. They are being used as growth promoters in these industries. So this is where the concept of one health becomes important. So animal, environment and human, all these three should pitch in, and that's how AMR can be controlled. Third thing is to have good effective vaccines for entropathogens, especially vaccines for Shigella and all. We don't have any vaccine, they are in the trial phase, so we need to have good effective vaccines to combat the resistance, tackle AMR, so that they don't get this problem at all. And then resistance, it is mediated through different ways, through plasmids, through different resistance mechanisms, and it is seen in almost all pathogens. NTS, non-typhoidal salmonella, then cholera is also becoming resistant to almost all agents. Tetracycline, chloramphenicol, all these bugs are getting resistant, and then that's it. So almost all the organisms are getting resistant to most of the antibiotics, the first line agents at least.
And antibiotic-induced diarrhea, the difficile challenge.
Yeah. So that was a second question. So that was on antibiotic-associated colitis or pseudomembranous colitis. So this is a particular entity which is caused by the organism Clostridioides difficile, which is a spore-forming organism. And this is generally seen in people who have been long-term treated on, been in the hospital getting antibiotics like ampicillin, clindamycin, etc. So there is a pseudomembrane that is formed, and it's causing a diarrhea-like picture. So again, if you restrict the use of antibiotics, this can be solved. And the treatment in this case is metronidazole or vancomycin. Diagnosis is by looking for the toxin. First step is by the GDH assay, which is dehydrogenase assay, and second one is the toxin detection. So that's about antibiotic-associated colitis.
Thank you. Coming back to Chitra ma'am, the immunization programs that we have for preventing diarrheal diseases in children, can you elaborate what is the status?
So presently what we have in the immunization schedule is the Rotavac vaccine, which covers the rotavirus. So it is introduced initially only in few states. Now it's there in the entire country. And so the Rotavac vaccine, it is given at 6, 10 and 14 weeks. And it is a freeze-dried vaccine with a diluent. So citrate bicarbonate is a diluent, and before using we can mix it with a diluent, and one while you can give 2 doses. So it is given orally at 6, 10 and 14 weeks. 2.5 ml is given to the child, and it is once used, it should be kept at 2 to 8 degrees Celsius, and it should be used within 4 hours after reconstitution. You can't keep it for a long time. And that is the main vaccine. Then indirectly there are studies have proved that measles vaccine and vitamin A supplementation also helps to decrease the diarrheal incidence also.
Thank you. Coming to the last question of the day, we discussed a lot regarding rehydration therapy. Can you just say regarding any specific medications? Like we said regarding zinc supplements. Any other anti-diarrheal or anti-secretory agents? Antibiotics we have covered already. Maybe can you just give me a quick overview. What are the additional therapies that we need?
So in children, actually the only treatment for diarrhea is ORS and the zinc.
Okay.
The zinc actually what the doses less than 10 kgs we can give 10 mg per day for 14 days. Like more than 10 kgs we can give 20 mg per day for 14 days. So that they are, and ORS as I already told, based on the dehydration status we have to give the ORS. And antibiotic indication only, like as madam told, bacillary dysentery, cholera, giardiasis, amoebiasis, etc.
Okay.
In pediatrics, in some cases, like in case of prematurely born children, malnourished children or young infants, sometimes this diarrhea may be an associated symptom of sepsis or any systemic infection like parenteral diarrhea. So in those children, if they are malnourished, prematurely born or young infants with inactivity, high spiking fevers, all these indicates points towards the sepsis. So in those cases also we may need antibiotics in addition to this infectious etiology like dysentery etiology. And in case of anti-motility agents, it is not at all indicated because it decreases the gut motility, it increases the bacteria like the flora to overgrow, and those symptoms will be there. So it is not at all indicated. Anti-secretory agents like resicodotril and all, the evidences are showing, limited evidences are only there. They are saying that sometimes it can reduce the stool output, the volume of the stool output and the severity, but the evidence is limited. Yeah.
Okay.
And the next thing is probiotics. Yeah. The probiotics also mainly they are saying Lactobacillus rhamnosus GG, Saccharomyces boulardii, etc. For around 1 week, but the evidence is again limited.
Okay.
So they are saying again this probiotics, basically the ORS, zinc, and the prevention, as madam told, the vaccine, rotaviral vaccine, because it is the most common cause of diarrhea in children. Okay. So the rotaviral vaccine, proper sanitation, proper nutrition, the breastfeeding. Okay. So these are the basic.
I think we had an exhaustive discussion for acute diarrheal disease in children, and I like to thank each one of you for elaborating in detail, starting with physiology, Vandana ma'am, community medicine, Chitra ma'am, and micro, Dr. Purnima and Dr. Shaila from pediatrics for your wonderful explanation. Thank you. Thank you all.